Welcome to this guide on transient weakness, designed specifically for postgraduate psychiatry residents. Understanding episodes of muscle power loss is crucial for identifying key differentials. We will break this down into three main categories: transient unilateral weakness, transient bilateral weakness, and fatiguable weakness. Let us start with transient unilateral weakness, which involves temporary weakness on one side of the body, presenting as a focal deficit. The first condition to consider is a transient ischemic attack, characterized by its brief duration, associated vascular risk factors, and typically affecting the face, arm, or leg. Next is hemiplegic migraine with aura, which presents with an associated headache and visual aura. You should also be aware of post-ictal paresis, known as Todd's paralysis. This follows a seizure, presents with focal signs, and resolves over hours or days. Finally, consider conversion disorder, or functional neurological disorder. This often involves psychological stressors, non-anatomical patterns of weakness, and an inconsistent physical exam, such as a positive Hoover sign. When assessing unilateral weakness, always ask about the duration of the episode, any speech or vision changes, and the patient's medical history. Moving on to our second category, transient bilateral weakness, which affects both sides of the body. A common cause is a post-ictal state following a generalized seizure, leaving the patient with diffuse fatigue. Hypoglycemia is another vital differential, presenting with low blood sugar, confusion, and sweating. Syncope or presyncope can also cause temporary bilateral weakness, marked by feeling faint, brief flexidity, and a quick recovery. Do not overlook electrolyte imbalances, such as hypokalemia or hyperkalemia, which can trigger episodes of periodic paralysis. Just like with unilateral weakness, conversion disorder can also present bilaterally. Our third category is fatiguable weakness. In these cases, weakness worsens with repeated muscle use and improves with rest. These are primarily neuromuscular junction disorders. The most prominent is myasthenia gravis, an autoimmune condition targeting acetylcholine receptors. Look for signs like ptosis, diplopia, bulbar symptoms, and diurnal fluctuation where symptoms change throughout the day. Another condition is Lambert-Eaton myasthenic syndrome. This is an autoimmune response against presynaptic calcium channels and can be a paraneoplastic syndrome, particularly associated with small cell lung cancer. It often presents with leg weakness and weak reflexes that actually potentiate or improve after brief exercise. To wrap up, here are your take-home points for psychiatric practice. Always rule out vascular and epileptic causes first. Consider conversion disorder only when typical functional features are present. Always note potential metabolic or electrolyte issues. And finally, recognize the signs of myasthenia gravis and Lambert-Eaton syndrome, especially when bulbar signs and symptom fluctuations are present.